Okay, good morning, everyone. After I think 2 Mondays, last Monday we had a break for Ganpati. Now we are again back to next on a fresh Monday at 6:30. Today is very important topic. I think in day-to-day practice we struggle with lots of patients managing their constipations in various stages, various forms, and various scenario. So today, this topic will be presented by a team from KMC Manipal, and the moderator is Dr. Krithika Rao. We all know Dr. Krithika very well. She's assistant professor with the team of Dr. Naveen Salins. Very brilliant, I think, young palliative care physician. I consider her. She is also leading the pediatric palliative care services at KMC Manipal, and her area of interest are also pediatric palliative care, ICU palliative care, and neuro palliative care. So, Kritika Arnavi is new for us. So, please introduce her as a first year junior resident, and please introduce her and then start this class. Thank you, Kritika and Arnavi. Yeah, go ahead, please.
Good morning, madam. Thank you so much for your kind introduction. It is always nice to meet you. And I would like to introduce Dr. Arnavi Udapure. She is our first year junior resident in Department of Palliative Medicine and Supportive Care at Kasturba Medical College, Manipal. And her main interests are always in psychosocial concerns of patients and caregivers. She's really efficient and diligent in her work, and she's really happy to be here presenting today on approach to a patient with constipation.
Good morning, everyone. The topic for today is constipation. So the subtopics that we'll be reviewing are going to be as follows: definition and classification, etiology of constipation in the palliative care settings, clinical approach and rectal examination, constipation assessment scales, principles of managing constipation and pharmacological approach for the same, classification of aperients or laxatives, detailed pharmacology of commonly used drugs, rectal products, pharmacological management of opioid-induced constipation, and management constipation in a patient with paraplegia or quadriplegia. So, constipation is defined like it is a clinical diagnosis characterized by stool infrequency, incomplete elimination of the stool, or difficulty in passing the stools. So the physiology of normal bowel movements. So mainly there are two kinds of innervations to the gut, which is the extrinsic innervation and the intrinsic innervation. So in this slide, we can see the extrinsic innervation, which is by the autonomic nervous system, which modulates motor and the secretory functions. So in this we have two, which are parasympathetic and sympathetic. The parasympathetic supply for the small intestine and the proximal part of the colon is going to be via the vagus nerve, which convey the visceral sensory pathways from and the excitatory pathways to the same area, which is the small intestine and the colon. And in this, the chief excitatory neurotransmitters are acetylcholines and tachykinins. Then again, for parasympathetic supply to the distal colon, it is supplied by the sacral parasympathetic nerves via the pelvic plexus. Now in this, the visceral afferents, they are going to convey the sensations from the gut to the central nervous system, and some afferent fibers also synapse in the vertebral ganglia, as we can see, and reflexly modulate the intestinal motility, blood flow, and secretions. The next kind of and then along with this parasympathetic, the sympathetic, it is excitatory to the sphincters and inhibitory to the non-sphincteric muscles. So this was about the extrinsic innervation. About the intrinsic innervation. Now, intrinsic innervation is capable of independently also monitoring this, but at the same time, it receives input from the extrinsic innervation as well. In this, we have three types, as we can see: myenteric, submucosal, and mucosal neuronal layers. So functions of these layers is modulated by the interneurons through the actions of other neurotransmitters such as acetylcholine again, then nitric oxide, vasoactive intestinal peptide, and norepinephrine. So in this myenteric, the one in yellow box that we can see, it regulates smooth muscles functions through intermediary pacemaker-like cells. And the submucosal ones, the ones in the pink box, affects the secretions, absorption, and mucosal blood flow. So that is about the basic physiology. Then causes of constipation, and this we can divide it broadly into three categories. One can be the local causes, which are the structural abnormalities, such as pelvic floor dysfunction, fecal impaction, patulous anus, and the others. Then the others can be the systematic disorders, such as the associated conditions, neurologic conditions, metabolic causes, motility abnormalities, and endocrine conditions. And the third one are the external agents, such as the medications and the diet. So medications are important ones for us to remember from palliative medicine point of view would be opioids, then calcium channel blockers, antihypertensives, or chemotherapeutic agents, especially the vinca alkaloids. Then coming to the classification of constipation, in this the very standard Rome 4 criteria is used, which categorizes the disorders of chronic constipation into 4 subtypes. We'll be seeing briefly about the each subtype. Firstly, we have irritable bowel syndrome with constipation predominantly. It is characterized with abdominal pain at least 1 day per week, where the pain is associated with at least 2 of the following. So in this, we have change in the stool frequency, change in stool form, and related to defecation. Additionally, patients have to have a report that the predominant stool abnormalities on days when they have abnormal stools is constipation. So that would be at least 25% of all stools, Bristol types 1 and 2, and less than 25% types 6 and 7. So about which the Bristol classification we'll be learning further on. Then the next type is functional constipation. In this, the abdominal pain is absent or not predominant or occurs less than 1 day per week. The symptoms of functional constipation must include 2 or more of the following. Now in this, a simpler way to remember would be that during more than 25% of defecations, that is more than 1/4 of the times, straining is present, or lumpy or hard stools, that would be Bristol stool 1 or 2, or sensation of incomplete evacuation, or sensation of anorectal obstruction or blockage, or manual maneuvers are needed to facilitate, again, more than 1/4 of the defecations, and fewer than 3 spontaneous bowel movements per week need to occur. Then opioid-induced constipation. The diagnostic criteria are similar to that of functional constipation that we saw, but with the requisite that new or worsening of the symptoms of constipation occurred when initiating, changing, or increasing the opioid therapy. Then functional defecation disorders. These include inadequate defecatory propulsion and dyssynergic defecation. These patients must satisfy the criteria for IBSC or functional constipation, but also demonstrate features of impaired rectal evacuation as demonstrated by 2 of the following 3 tests, which are abnormal balloon expulsion test, abnormal anorectal evacuation pattern with anorectal manometry or anal surface electromyography, impaired rectal evacuation on defecography but without the structural lesions. Then coming to etiology of constipation in palliative care settings particularly, in this the risk factors can be advanced disease, older age, decreased physical activity, low fiber diet, depression, cognitive impairment, hemorrhoids, and polypharmacy. In medications, as we had previously also discussed, opioids, calcium channel blockers, diuretics, anticholinergic drugs, iron, serotonin antagonists, and chemotherapeutic agents, especially the vinca alkaloids, thalidomide, vandetanib, they can lead to constipation. Then neural causes such as epidural spinal cord compression can lead to constipation. And other metabolic causes include hypercalcemia, hypothyroidism. So in this diagram, we can see in a pictorial representation. So low bulk of food can lead to constipation. Then psychogenic reflex disorders can lead to the same. Then surgery, trauma, peritonitis can lead to paralytic ileus, resulting in constipation. Otherwise, mechanical obstruction, neurogenic or myogenic disorders of transport, and drugs can lead to constipation. Also, obstruction and pseudo-obstruction can lead to the same. Then clinical approach and rectal examination. So first and foremost is to exclude the organic etiology in a cost-effective and judicious manner. While taking the clinical history, duration and nature of the constipation should be established and the stool consistency needs to be assessed. So for assessing the stool consistency, very commonly we use the Bristol stool scale, in which type 1 and type 2 are like the harder stools, which indicate constipation. Type 3, type 4, type 5, normal stools, and type 6 and type 7 are indicative of diarrhea. Then the presenting complaint should also be elicited for the presence of other gastrointestinal symptoms, as well as the other alarming symptoms, which can maybe lead to a diagnosis of malignancy. Then physical examination, in which we assess for the presence of abdominal masses, lymphadenopathy. Anal orifice needs to be examined for fissures or mass lesions, and a digital rectal examination needs to be undertaken to palpate for anorectal strictures. And if unremarkable, we ask the patient to bear down to assess for perineal descent and anal sphincter relaxation. The presence of paradoxical anal contraction may imply dyssynergic defecation, which will lead to functional constipation. And then limited laboratory tests include blood tests for anemia, inflammation, hypothyroidism, hypercalcemia, and celiac disease. And a transabdominal or vaginal ultrasound scan can also be performed in postmenopausal women with recent onset constipation, localized lower abdominal pain, bloating, or distension. Finally, we can go to the further investigations, such as colonoscopy or cross-sectional imaging, balloon expulsion test, and anorectal manometry. Then coming to the management for constipation, the very basic goals are going to be often resetting expectations as the first step, which means that we need to understand what does the person exactly mean by feeling constipated. Then balancing stool frequency and consistency with comfort and dignity, and to incorporate individual preferences, as is the thumb rule for palliative medicine. Then contributors to constipation. Now, for a normal bowel movement to occur, there needs to be solid waste, water content, lubrication, and motility. So if any of the four things get disturbed, it can lead to constipation. So coming to the non-pharmacological treatment as the next step, in this, we would advise for more fiber-rich foods, increased physical activity, increased fluid intake, and ritualized bowel movement. And coming to the pharmacological management of constipation, in this, we'll look at the classification of the aperients. We have bulk-forming agents such as dietary fiber, psyllium, isafgola, stool softeners such as docusades, liquid paraffin, and stimulant laxatives such as bisacodyl, sodium picosulfate, senna, and osmotic laxatives such as lactulose and macroloids. Now, looking into each of the topics, so bulk forming agents, the general features or the mechanism of action includes that it absorbs water in intestines, forms bulky gelatinous mass, increases the bacterial load, and softens the feces. Now, these agents work both in the small and the large intestine and are used as the first line therapy in patients with mild chronic constipation. In the individual agents, we have Paran, but the disadvantage for it is that large quantity needs to be ingested. It doesn't soften the stools that are already present. For psyllium, it can lead to adverse effects such as flatulence, abdominal distension, fecal impaction, and bowel obstruction. Methylcellulose, it is a semisynthetic colloidal hydrophilic derivative of cellulose, and it is largely unfermented in colon. Next are the stool softeners. They soften the stool and thus make them easier to pass. And then it works in the colon. In this, we have docusate sodium, for which the onset of action is 12 to 72 hours. It disrupts the mucosal barrier and enhances the absorption of non-absorbable drugs such as liquid paraffin. The adverse effects include diarrhea, nausea, abdominal cramps, and hepatotoxicity. The dosing is 100 milligram twice a day, and it can be increased to 200 milligram twice to thrice a day. Then we have liquid paraffin, which is pharmacologically inert. The dosing is from 15 to 30 ml per day. The adverse effects includes vitamin A, D, K deficiency, which are the fat-soluble vitamins, and also can lead to lipoid pneumonitis, especially in bedridden patients. Then stimulant laxatives. So how do they work? They work by increasing the gastric motility by acting on the myenteric plexus, which is a part of the intrinsic innervation that we studied about. Then it can lead to accumulation of water and electrolytes in gut lumen. It leads to altered absorption by inhibiting sodium potassium ATPase at basolateral membrane of villus cells. And it causes enhanced secretion by activation of CAMP in Crypt cells, increases prostaglandin synthesis, and thus irritates the lining of the intestine. So coming to the individual agents, we have bisacodyl, which is a prodrug. It can either be administered orally or as suppository, as all of us know. It is absorbed in the intestine and it is excreted in the bile. The adverse effect is that it can lead to local rectal inflammation. The dosage is from 10 to 20 milligram at night time, or it can also be 20 milligram thrice a day. Then sodium picosulfate, it is a prodrug. Bowel movements occur 6 to 12 hours after the oral dose. The dosing can be 5 to 10 milligram at night, maximum up to 30 milligram. Then senna, it is an inactive glycoside. It passes unabsorbed and unchanged to the small intestine. Adverse effects can be skin rashes, fixed drug eruption, melanosis. The dose can be 15 milligram at night to 30 milligram 3 times a day. Then osmotic laxatives. For these, the mechanism of action is by they lead to deposition of large volume of fluid into the large intestine. It can be used for post fecal disimpaction for achieving daily defecation. Firstly, coming to lactulose, it is a semisynthetic disaccharide of fructose and lactose. Adverse effects are flatulence, cramps, and nausea. They are fermented in large intestine into acetic, formic, and lactic acid and thereby increasing the fecal acidity and stimulating peristalsis. The contraindications are intestinal obstruction and galactosemia. Polyethylene glycol, also known as microvol, they are unchanged and unabsorbed in the GI tract. They are much safer to use in the older adults, have less risks of leaking, then reduces colonic bacterial flora. Adverse effects, however, are abdominal bloating and discomfort, and contraindications are severe inflammatory bowel conditions and bowel obstruction. Magnesium salts, they lead to release of cholecystokinin, decrease the absorption or increase the secretions in small bowel. Adverse effects are the risk of hypermagnesemia, especially in patients with renal impairment. We'll be looking a bit more into the use of lactulose in hepatic encephalopathy. So acidic breakdown products of lactulose are formed, hence lowering the pH of the stools. Then it discourages the proliferation of ammonia producing organisms and also reduces absorption of ammonium ions and other nitrogenous compounds, thereby helping in the patients with hepatic encephalopathy. Moving on to the newer agents, in this we'll be talking mainly about the two categories. First are the guanylate cyclase A receptor agonists. In this we have two drugs. First is linaclotide. It is a minimally absorbed peptide agonist of the guanylate cyclase C receptor that stimulates intestinal fluid secretion in transit. The dose is 145 micrograms daily. The most common and dose-related adverse event is diarrhea. Then next we have plecanatide, which has been approved by the US FDA for the treatment of chronic idiopathic constipation at a dose of 3 milligram daily, for which the most common side effect again is diarrhea. Then we have lubiprostone, which is a locally acting chloride channel activator that enhances chloride-rich intestinal fluid secretion. The most common side effect in this case is nausea, which is dose-dependent. And this drug is best reserved for patients with severe constipation in whom other approaches have been unsuccessful because it is expensive and also because it induces nausea. The other agents include prucalopride, misoprostol, and colchicine. Rectal products. In these, the indications include constipation and fecal impaction after the oral laxatives are ineffective. So in this, we'll be looking at suppositories, micro and standard enemas. Suppositories, they can either be glycerol suppositories, which are osmotic, that is, they have hygroscopic and lubricant action. Then bisacodyl, also known as Sorbet suppositories, they are stimulant in their mechanism of action, which means they stimulate the propulsive activity after hydrolysis by the enteric enzymes. Microenemas, again, are osmotic. They contain sodium citrate, sodium lauryl sulfoacetate, glycerol, and sorbitol. Or they can be fecal softeners, such as docusate sodium. And standard enemas are usually osmotic in nature. They contain phosphate. Now coming to the subtopics that we are going to discuss in detail. First one is opioid-induced constipation. So why are we studying this? Because firstly, in opioid-treated cancer patients, the prevalence of constipation can be as high as 60 to 90%. That is the reason why we should be knowing to how to manage this, and also because it can lead to a lot of distress. Then the contributory factors. So, like, what is the pathophysiology? Opioids bind to specific receptors in the gastrointestinal tract and the central nervous system to reduce the peristalsis, which leads to excessive water and electrolyte reabsorption from the feces and reduced biliary and pancreatic secretion. And all of this will lead to dehydrating of the stools. Then concurrent factors such as use of other constipating drugs, dehydration, advancing age, immobility, metabolic abnormalities, chemotherapy, and tumor-related bowel obstructions can also add on to the constipation. And usually the non-oral route is less constipating than the oral route, hence it is preferred. Then common strategies for managing opioid-induced constipation. So step 1, as always, is non-pharmacologic approach unless contraindicated by the medical status, in which we have increased fluid intake, increased dietary soluble fiber, encourage mobility, and ensure comfort and privacy for defecation. Then pharmacologic strategy, in which we have intermittent use of rectal therapy, either a suppository such as bisacodyl or glycerin or mineral oil and or sodium phosphatemia. Intermittent use every 2 to 3 days of an osmotic laxative such as polyethylene glycol, magnesium hydroxide or magnesium citrate. Trial of a daily softening agent such as Locusert for patients who described hard dry stools. Intermittent use every 2 to 3 days of a contact cathartic such as senna or bisacodyl, and daily use of either polyethylene glycol or lactulose unless lactose intolerant, or sorbitol, or the daily use of a contact cathartic. Then we need to adjust the dose and dosing schedule of the selected therapy to optimize effects. In this, we need to take care to optimize both the pain relieving effect as well as how to manage the constipation. Then switch or combine conventional approaches if initial therapy is inadequate. And finally, consider adding a peripheral opioid antagonist such as methyl naltrexone, naloxone, or an opioid naloxone fixed combination or lubiprostone. If constipation continues to be refractory, consider alternative drugs, example metoclopramide, which is a prokinetic. Then management. In more detail, the most common regime for opioid-induced constipation is a stimulant with or without a stool softener, or daily administration of an osmotic laxative. Increased dietary fiber, fluid intake, and physical exercise are the backbone to prevention therapy. All the types of laxatives can be used as initial therapy except for the bulk-forming laxatives, as they increase the bulk of the stools, distend the colon, and augment the peristalsis. Whereas opioids will prevent the peristalsis of the increased bulk, which will lead to worsening of the abdominal pain and will contribute to bowel obstruction. Then management of opioid-induced constipation can be difficult to do so because usually it is multifactorial, as we discussed previously. It can be because of the illness, medications, reduced fluid intake, loss of appetite, and also because patients may have secondary constipation caused by a range of disorders, such as stenosis, endocrine or metabolic disorders, neurological disorders, enteropathic neuropathies, other disorders, and it can also be induced by a variety of common drugs, also because laxatives have a non-specific action. An opioid should not be decreased to manage constipation unless absolutely necessary. Doing so may expose the patient to significant pain, and prescribing prophylactic laxatives with opioids is thus the recommendation. Summarizing, like before that, the final thing would be to discuss about the opioid antagonist. Methyl naltrexone bromide is the first available peripherally acting opiate antagonist, which is used to treat opioid-induced constipation. It does not cross the blood-brain barrier, which doesn't induce the symptoms of opioid withdrawal, which is the advantage. Subcutaneous methyltrexone was found to be significantly better at reversing opioid-induced constipation than lubiprostone, naloxone, and oral methyl naltrexone, and it should not be used in patients with peptic ulcer disease, diverticulosis, colon cancer, or obstruction. Other therapies include naloxone, alvimopin, and naldomidine. Naloxone and naldomidine are both approved for treatment of the same in patients with non-cancer pain. So finally, coming to the summary of the management of OIC. In this, according to the ESMO guidelines, unless contraindicated By pre-existing diarrhea, all the patients receiving opioid analgesics should be prescribed a concomitant laxative. Osmotic or stimulant laxatives are generally preferred. Bulk laxatives such as psyllium are not recommended. In unresolved OIC, peripheral opioid antagonists such as methyl naltrexone or naloxone may be of value, and combined opiate or naloxone medications have been shown to reduce the risk of opioid-induced constipation through both open-label phase 2 and phase 3 studies. Then coming to the last topic for the day, managing constipation in a patient with paraplegia or quadriplegia. So in this, we have two types of lesions, which are the upper motor neuron lesions and the lower motor neuron lesions. So upper motor neuron lesions in this case include the injuries above the level of the conus medullaris, whereas for lower motor neuron lesions, we have the injuries at or below the level of the conus medullaris. In upper motor neuron lesions, what happens is that hyperreflexic pelvic muscle contraction occurs, because of which there is an inability to voluntarily relax the external anal sphincter, leading to fecal retention and hence constipation. Whereas in lower motor neuron lesion, it leads to slower transit and decreased sphincter tone, leading to causing constipation with frequent incontinence. So how are we going to manage it? First and foremost is the goal of predictable and timely bowel evacuation to form a consistent structured regimen, which is integrated into the patient's lifestyle as early as possible after the spinal cord injury, which need not always be traumatic. It can also be because of malignancy leading to spinal cord compression, using the pre-injury bowel pattern as a guide. A typical routine may begin at a regular time point each day, for example, 30 minutes after a meal, with insertion of a chemical stimulant, rectal suppository. Then, after several minutes, digital stimulation with slow, gentle rotation of the finger for 15 to 60 seconds is repeated every 5 to 10 minutes until the stool evacuation is complete. Abdominal massage, deep breathing, Valsalva maneuvers, and forward-leaning position may assist evacuation. Oral bowel medications are often used during the initial phase of establishing a regular bowel pattern and then are slowly eliminated. A regular diet is an important feature and should contain adequate fiber intake, that is around 30 grams, and relatively lower amounts of dietary products and fat content. And in case if constipation or fecal impaction develops, a trial of enemas, laxatives, or bulk forming agents may be considered. Abdominal radiographs should be considered to screen for evidence of obstruction, and if diseases not related to the spinal cord injury, particularly colorectal cancer, should be excluded. Prokinetic medications, example metoclopramide, are reserved for persistent severe constipation that is unresponsive to modifications of the bowel program, and some patients with severe bowel dysfunction may require a colostomy. Then coming to the summary of the subtopics that we discussed today, constipation is a clinical diagnosis characterized by stool infrequency, incomplete elimination of the stool, or difficulty passing stools. Physiology, as we saw, it is either small intestine, proximal colon, distal colon, and intrinsic, extrinsic innervation. Intrinsic, again, we have three: myenteric, submucosal, and mucosal neuronal layers. Extrinsic would be parasympathetic, sympathetic, like that. Then definition and classification according to the Rome-4 criteria. We also learned about how the stool consistency is assessed using the Bristol stool scale. Then we saw about the management, first non-pharmacologic, then pharmacologic. Pharmacologic, we saw types of aperients, which are bulk forming, osmotic, stimulant, stool softness, and the newer agents. And also on the basis of the site of the action, like whether they work on the small intestine, large intestine, or the both. And finally, we studied about the two subtopics, which were opioid-induced constipation and constipation in cases of patients with paraplegia and quadriplegia. Thank you.
That was a very nice and exhaustive presentation, Arnavi. And I know it looks like a small topic, but it isn't. Actually, it is one of the most important things that we come across in palliative care settings. And just as a summarize, to understand like an algorithmic pattern when we are trying to manage such patients, one of the most important things that we need to address when we see such patients with advanced illness in our clinical settings is, as foremost, she explained about thorough clinical history and examination and assessing for all patients for wherever you can prevent constipation to occur, mainly with where we are prescribing drugs. We use a lot of opioids, and that is one of the points that we should remember is always have an anticipatory prescription given whenever opioids are first initiated to prevent constipation. And when we are evaluating for, suppose a patient presents with that, and if it is less than 3 weeks of less than 3 bowel movements per week, or they have any instance of incomplete evacuation, or they're passing hard stools or straining or not even passing flatus, always look for whether there is bowel obstruction or not. Because before we start any aperients, any other laxatives, or give any suppositories, any rectal measures, always look for that first, rule that out before we start oral management. Because if it is a complete bowel obstruction, it is not going to help. So that is one of the most important points to be kept ahead. And when we are choosing laxatives, so there are certain guidelines I would like to share later on further, but just as a concise on that, mainly when we are looking at pharmacological management, there is grade A evidence for using osmotic laxatives, polyethylene glycol and lactulose as supported in the evidence, but we don't use docusets or mineral oil. It's not at all recommended. Stimulants such as senna-based laxatives and bisacodyl can be used, but they have insufficient evidence. Senna may cause a lot of cramps in the abdomen, so bisacodyl is what we can prefer to use it. And despite all of these oral measures, if constipation still persists, an enema or suppository can be done. So based upon whether it's hard feces, then a phosphate enema is recommended because it is one of the better agents to help in liquidizing of the stools if it is impacted. And if it's just the softer feces on digital rectal examination that you have evaluated, a stimulant works better, or like a bisacodyl suppository. If it not, then a phosphate enema can suffice. So these are important, but along with that, a regular monitoring of these patients frequently should be done in, and they should present in again to the OPD if they have not been relieved of their initial presentation of symptom. And if there's a change in prescription that you would want to consider, always look through the other factors that could also contribute to constipation, because it might not always be that you can manage with medications itself. You should try and see diet modifications, other non-pharmacological methods, as well as at times we might have to change drugs as well, which is one of the main causative agents for constipation. So, I mean, with this, I would really like if there are any questions.
There are some question. One question, Krithika, can you take up this question from Divya?
Yeah, Dr. Divya Sai has mentioned managing opioid constipation in children. Dosage, can a stimulant laxative be given? Yes, we do give bisacodyl in preparations in children as well. And a lot of times, especially patients with leukemia who are on vinblastine protocol for chemotherapy, it is recommended that they be on a lactulose base or PEG based laxatives throughout their treatment, so as to prevent constipation as well, because vinblastine will cause severe constipation or impacted feces as an issue. So that is recommended to continue while they're giving, and you can safely give bisacodyl in such patients. And the next question is, a patient on opioids and having a chemo or RT-induced diarrhea, should laxatives be temporarily discontinued? I mean, yes, during that treatment period, when they're actively passing more than 6 to 7 stool outputs per day, it should be monitored. At the same time, for other dehydration symptoms should also be looking for electrolyte abnormalities that might turn up with this.
Sushma, can I respond to that
Yes,
question?
please, Nandini, go ahead.
Yeah,
Yes,
thank you. So one important thing to remember in children, most commonly we handle children who may have been on chemotherapy. So, rectal maneuvers, for example, an enema or even a PR examination or a suppository, we need to think carefully, because in a patient with, evolving neutropenia, when we do rectal maneuvers, it can trigger an infection because slightest of mucosal injury and there is bacteremia. So that is one, we can trigger the neutropenic sepsis by doing something per rectal, either an enema or a suppository. So that is one point I wanted to emphasize.
Thank you, Nandini, madam. Yes, that is one of the most important points to be remembered.
So, anyone wants to add anything? Naveen, would you like to add anything to this lecture? And Dr. Jennifer, would you like to add some practical points for youngsters?
Yeah, thank you. That was an excellent presentation. I think you've nicely covered everything related to constipation. Just to add on to what Nandini mentioned, I think that's a very important point. One is neutropenia sepsis. The other thing is also thrombocytopenia. So keep that also in mind. The other point in history taking and examination, which I wanted to bring out, was spurious diarrhea. So one of the ways of presentation of chronic constipation can be spurious diarrhea, and many of us might think leakage of stools or passing small amounts of frequent stools and treat it as diarrhea, not considering underlying constipation. So it's important in history taking, if patients say small amounts of frequent stools leaking, whether it is overflow diarrhea, and that can be only confirmed by getting a past history of constipation for a while and also a per rectal examination. So I think in palliative care, if anyone is having constipation for more than 3 days, per rectal examination in those who are not on chemo, we are not thinking of neutropenia, thrombocytopenia is something very important. And also to emphasize prophylactic laxatives, again, prevention of many symptoms is crucial. So prophylactic laxatives where you anticipate constipation either because of medication or immobility or bedridden patients. So these are the couple of points I wanted to emphasize. Thank you.
Thank you, Dr. Jennifer. It's absolutely important point is spurious diarrhea. I think people missed it many times, and it is important to have to know that rectal examination is going to help if patient is having spurious diarrhea. So they should recognize it and treat it properly.
Sushma, I would like to comment if possible.
Yeah. Yes, please go ahead. Go ahead.
So regarding, I'm not sure whether this was covered, maybe I have missed it, but per rectal examination, you're likely to find generally 3 scenarios. One is that, it's loaded and then you may use either a suppository or you may continue to use oral therapy. But if it is, or if it is dry, you may have to do some amount of manual evacuation. Third thing is if it is empty and ballooned, it indicates a constipation which is little higher up. It has not reached the rectum. The balloon, you can actually move your finger. Usually it just, embraces the finger because of the contraction. But if it is, you feel the space in the rectum, it means that the motion is stuck higher up. And that is the time to use high up enema, where the nozzle of the enema is extended through a catheter, which is very nicely lubricated. And then so that, it enters a point which is higher to rectum, maybe at least up to sigmoid. And then 2 enemas are given because now you are covering a larger volume. So sometimes they will say enema was given, but still the motion didn't go. But the regular enema only fills the rectum. So you may have to give a high up enema in a chronic constipation. And then you will get a good response. So that was another point. I'm not sure whether it was discussed before I stepped in. Yeah, thank you.
Thank you, Nandini. I think these are again a very important point. So all the students and the people, those are practicing palliative care, this is important to learn that how important it is to do fecal evacuation and giving high up enema. I have seen we are not practicing these small things regularly, but it is important that what is the scenario, and based on the scenario, all these small practice are important to manage constipation. So, are there any questions? And there is one question from Dr. Rajesh, and there is one question from Acha, Anuja has given the dose of Bisacodyl. Okay. So there is one question from Rajesh. Krithika, would you like to address that?
Yes, ma'am, I just answered it as well. It is once in 24 hours is a maximal dose for safety and use of phosphate enema as per the guideline recommendation.
Okay, thank you. So,
She has her hand raised up. I think she's wanting to ask a question.
okay, go ahead, please. Go ahead.
Meenakshi, you can unmute.
Yes, good morning, ma'am. Very good presentation, Dr. Arnavi and Dr. Krithika. A couple of points that I wanted to raise. One is when we ask a history for bowel movements, very important to ask what is the routine of the patient. It's highly variable. Bowel habits are highly variable in the population. So there may be patients who go 3 times in a day. There may be patients who normally go once in 2 days. So establish what is the normal frequency in their premorbid condition. And then that may, and don't titrate the laxative to a certain frequency. It is to ensure a painless and comfortable defecation movement every day or every other day, depending on the condition of the patient. That's one point. Second point is, again, the normal squatting position, it relaxes the puborectalis sling, which facilitates defecation comfortably. And this is lost in the concept of Western toilets. So now they have introduced a small change that is to raise the lower limbs using a footstool. So that's a fairly cheap alternative and a non-pharmacological method that one can use for some patients. The third thing is in the era of a lot of targeted agents and tyrosine kinase inhibitor use, patients will already have diarrhea and excessive bowel movements because of those agents. So it's very important to spend some time, spend time in every sitting, asking whether they are having to use the laxative at all or not. So to customize the laxative use to their bowel movements. And lastly, in patients who have colostomy, you may or may not require a laxative every time. So again, the patient has to be educated for the same. There was one question for pediatrics. Less than 6 years of age, stimulant laxative like bisacodyl may not be warranted. And in fact, I remember from an earlier lecture that it's probably not recommended to use a stimulant laxative. If you're using bisacodyl or sodium pycosulfate, please do remember to ask the patient whether they are having colic with the use of such an agent, and tailor the number of tablets depending on the occurrence of colic. Thank you.
Meenakshi, excellent and wonderful. Thank you very much for again highlighting very, very important points. So imagine there are so many things to learn in constipation. So we consider this as a patient comes, and I think 60 to 70% patient, they will come and say they are not passing stool properly and they are distressed because of this. And we always just think that morphine causes constipation, but there are so many things to learn in constipation. Thank you, Krithika and the team. Anyone wants to have any comments, please?
Ma'am,
Raise your
Sandy
hand.
sir has raised his hand, sir.
Okay, please go ahead.
Sorry for joining late. Constipation is such an important thing for us in palliative care. And if you have gone to the stage of manual evacuation, it's a terrible thing to subject a person to, the loss of dignity, loss of, the severe pain and everything. So you come to the stage of manual evacuation, it's an indicator that your palliative care has failed. So we have to be active, starting with, say, day 2. If they're not passing, get on to measures, maybe suppository rectal measures and things like that. Also, one of the things I found useful is if the stool is hard, and the person is not able to pass easily, is to just allow him to do a simple rectal massage, just pressing the buttocks alternatively, so that it stimulates the rectal mucosa, and they are able to pass. And also some of the food items that we can use, especially this sesame balls, till balls. You can use that because it is also providing some roughage, and also there is oil in it. It's a lubricant-like thing. So all these things help. Thank you.
Thank you, Dr. Stanley. I like the statement that your palliative care has failed if you have reached to the stage of manual evacuation. I know this is it's not very easy for patient, and it's quite demoralizing. But in certain situation, we will have to definitely do manual evacuation as well. But it should be rarest of rare incidents, definitely. So there is one more question from Manish. Any role of pelvic floor exercise in chronic constipation? Or any role of acupuncture also, Krithika? About
Madam, Dr. Manish, with regards to pelvic floor exercises, so before if there's a functional constipation that is causing in, or there are various tests that is done. So there is something called as a rectal balloon manometry done to evaluate whether it is involved with it's a functional issue, or is it due to the local impactions. If it's a functional issue, then yes, pelvic floor exercises can help in, but it is more in terms of when cases of incontinence is present due to that. Otherwise, it does not really play a role. So before prescribing that, they need to undergo certain testing, especially the rectal balloon manometry, to understand whether it's functional or not.
Oh, thank you. Thank you, Krithika. And thank you, Arnavi. I don't know whether I have pronounced it.
It's right.
Thank you very much. Our first year residents are becoming brilliant. They are presenting so well this important topic, which everybody should know. And I hope that everybody has come to know that there are so many other things to learn in constipation besides writing bisacodyl and clemifene plus, or only for morphine induced constipation. There are so many other things to learn. We can't see any other questions. Any other raised hands? No. So,
Ma'am, one more
thank you,
point I
Krithika.
wanted to say. Sorry, ma'am.
Yes, Meenakshi, please go ahead.
Ma'am, just wanted to emphasize to all the students that when you're doing a PR examination, which is a must in patients who have constipation, please remember to take consent. I mean, not a written consent. What I mean is a verbal consent. Explain the procedure, because it's like Dr. Stanley mentioned, it's a real invasion of privacy. So people will be very hesitant to undergo the procedure. So please, explain to them that it will not hurt. Give them adequate privacy. Position them well. Use good lubrication and deep breathing techniques so that the patient can relax. So because lack of privacy and time is one of the biggest factors in hospitalized patients, which causes constipation in the first place. So that's very important. And in you did mention in LMN lesions below conus medullaris, you did mention the maneuvers. Actually, in those kind of patients, it's probably better to avoid oral laxatives and use rectal maneuvers every third day, because they may have a patulous and lax sphincter causing incontinence, which makes nursing them very, very difficult. Thank you.
Thank you very much. Now I want to tell you. Yeah, go ahead, please. Somebody wants to say
Nandini.
something.
Nandini.
Nandini,
One, again, as she was talking about the rectal maneuvers, I remember that one of the common reasons that patients have such a bad experience of enema is because of lack of all this. And one more thing that I have noticed, in a hurry, sisters sometimes cut the nozzle of the enema. Instead there is a snipping we can do, because when you cut it, the edges are very sharp and it hurts. And you will actually, there may be some slight bleeding also, but there is a way to snip it. Then the edges are rounded, and that, with a lot of lubrication and conversation, we need to do that. Then only they will have it as an pleasant, at least not unpleasant experience. Thank you.
so thank you, Nandini and Meenakshi. Very, very important points again. Dr. Rajesh has raised his hand.
Yeah.
Rajesh, would you
Ma'am,
like to say something?
yes,
Rajesh?
ma'am. I find that there are two causes of failure of enema. One is that the formulation, especially in the government sector, may change daily. For example, you are telling Cremafin plus, and next time it would be Cremafin. And if the formulation changes and the bottle doesn't has a cap, the dose of the dose which patient is taking also keeps on changing. If he get another formulation, he may take 2 small spoons or other. So we have to tell the patient in ml that how much dose
This is also a very practical point, that if we have not explained properly,
so
patient
that
is
they
just taking 1 teaspoonful. Any other
one
thing? Yeah.
madam, they can use a syringe. We use give a 20 ml syringe, and we tell them that they should take in measurement not in teaspoons. They usually take very erratic doses. Matlab they may take 1 teaspoon, 2 teaspoon. You don't know they are taking complete doses.
Good idea. I think 20 ml syringe, giving them 20 ml syringe. Good idea.
Then they take regular dose, ma'am. That is one of the major cause of failure. Because once Cremafin plus is not there, another formulations do not have a fixed cap of 15 ml, ma'am.
Dr. Rajesh, I think this is a good idea. So we can't see any other comments, and thank you very much, Krithika. And again, I said that first year resident, I feel very happy whenever a first year resident present brilliant the topic, which looks like very simple, but give a lot of insight about this topic. I just want to say that as Dr. Stanley say that your palliative care has failed if patient is having constipation. So best is to do as much as possible in all possible scenario that this may cause constipation. Explain your patient well about the hydration and about the importance of taking fibrous diet, and try that patient should not have constipation. So do this study that I have done. I have given extra 5 minutes to explain to everything, all possible things to my patient, and whether she or he was having constipation. So this will definitely reduce the incidence of constipation in your day-to-day practice, because as you have seen today, that it is so difficult and it is so demoralizing for patient to have constipation, because it is distressful if patient is having constipation. So again, there is a announcement that there will be no lecture due to Gandhi Jayanti next week, and next session will be on 9th October from team MNJ Hyderabad, led by Dr. Gayatri. So we will see you again on 9th of October with the next important topic, and very just look for it, and we will see you on 9th October, and we will eagerly wait that everyone will join for another very important topic on 9th October. Thank you very much. Thank you once again, Krithika and Arnavi, and everyone for joining. Your presence is most important, and thank you, Nandini, Dr. Jennifer, Dr. Meenakshi, Dr. Stanley, Rajesh, and everyone for your comments and important input on this topic. We will see you on on 9th of October. Till the time, enjoy your days, and have a wonderful day today. Thank you, Archana, and thank you, Nisha. Thank you very much.